This is Professor Nicholson lecturing on applying the nursing process to the care of the family during labor. Please review all the sub-competencies on your own for Unit 3, Module 6. Maternal assessment during labor and birth includes monitoring vital signs per policy of the unit, of course, recognizing pain, reviewing the prenatal record, conducting vaginal examinations, which will be explained further on the next slide. The nurse should also recognize rupture of membranes. You should know that AROM is artificial rupture of membranes, also known as amniotomy. This is only performed by the certified nurse midwife or OB per hospital policies, of course. The provider uses an instrument that resembles a crochet hook, as you can see in this image. After an amniotomy, the nurse's priority is to monitor the fetal heart rate. Again, the nurse needs to monitor the fetal heart rate after an amniotomy. That is very important. SROM is spontaneous rupture of membranes. It is important to know time and color of rupture of membranes. As I've mentioned in previous lectures, if the meconium is stained, this increases the risk for meconium aspiration syndrome at delivery, and additional help should always be present during the delivery. We will discuss contractions shortly, and then lastly on this slide, Leopold maneuvers are used to determine the baby's position. It can also estimate the baby's birth weight. This maneuver also helps nurses determine where to place the fetal monitoring device to hear the fetal heart rate the best. I always tell everybody the back is best. This slide gives you a little bit of perspective on a vaginal examination. As you can see here, this is a nurse or a provider doing an examination, and yes, sometimes you can feel the baby's head depending on how dilated that cervix is. So moving on to dilation. So this is how opened the cervix is. It can be anywhere from a fingertip in width all the way up to 10 centimeters. This shows you different ranges of the dilation, and this shows you a fully dilated cervix so that the baby can come out, of course. Effacement is how thinned out the cervix is. So you're looking at this image here. For example, is the cervix 50% thinned out, like this image? Is it 100% thinned out, so paper thin, or is it not even thinned out? It gets a little bit more complex when you talk about the fetal station over here. This is also known as the descent of the fetus into the pelvis. It ranges from -5 to +5. So -5, of course, is deeper in the pelvis, and +5 would be crowning. 0 indicates that the head is aligned with the ischial splines. See right here. The fetal heart rate should be assessed upon admission, as mentioned. This requires a 20-minute non-stress test. A non-stress test has to be reactive, which we will talk about shortly. Regarding the electronic fetal monitoring system, you should know this bottom portion is the ultrasound, which listens to the baby's heart rate, and the top portion here is the toco. It looks like it has a little button on it, and when the uterus contracts, it applies pressure to the button, so that's how we're able to see contractions on the monitor. Regarding the Leopold maneuvers I talked about earlier, this just gives you another perspective that the nurse should be conducting this assessment to know where the baby's back is, because it gives a better sound for the ultrasound. Remember, back is best. Just a little bit more about the continuous electronic fetal monitoring system. Just note you might also see it written as EFM, so those are the abbreviations. It uses a machine to produce continuous tracing of the fetal heart rate. Remember the ultrasound and toco? These are what the attachments are. They hook right up into the monitor here. It provides information about fetal oxygenation and prevents fetal injury from impaired oxygenation. That's why it's so important for us to be able to recognize different fetal heart rate patterns, which we will discuss shortly. It can also detect fetal heart rate changes early before they are prolonged and profound. Fetal assessment during labor and birth always, of course, involves an amniotic fluid analysis. Regarding fetal heart rate monitoring, you should know there are handheld devices, such as this Doppler up here. And there's also the electronic fetal monitoring system, such as what is in the previous slide that we discussed. There's intermittent versus continuous options. So intermittent is performed based off hospital policy. It's when we can listen to the heart rate maybe every half hour or every hour versus continuously. It allows the patient to get up and move around more. Then there's also external and internal devices. So external would be that Doppler or that electronic fetal monitoring system. An internal device would be the internal fetal monitoring system down here. It's a little electrode that twists into the baby's scalp, and the device goes up through the vagina, right through the scalp here. This is only placed by a skilled provider. Nurses are typically not allowed to place those, but some facilities allow it. In order to have an internal fetal heart rate monitor, there are requirements. So the membranes have to be ruptured, and the cervix has to be at least 2 centimeters, and the presenting fetal part should be low enough to allow placement of the scalp electrode. So why do we use internal fetal monitoring devices? Because sometimes the nurse has a hard time measuring the fetal heart rate externally, and this just provides a much more thorough assessment of the heart rate. Fetal heart rate patterns will be discussed shortly. I do want to also note in this slide there is an intrauterine pressure catheter, which we will talk about shortly. So if you need to refer back to a picture, this would be the one to go to. As we move on into fetal heart rate patterns, please note these are key terms related to fetal heart rate. I highly recommend you get to know this mnemonic. I additionally provided mine, which is a great way to understand priority interventions based off of the pattern. I want you to note that deceleration type is identified by continuous monitoring only. If a nurse hears a deceleration while using a fetal heart rate Doppler, so intermittently auscultating, the nurse must bring the patient back to bed and place the patient on the monitors to get an accurate description of what is going on. Before I get into these different patterns, I want you to remember fetal heart rate ranges between 120 and 160. You need to know how to interpret fetal tachycardia and fetal bradycardia. For instance, if a fetal heart rate baseline is up in the 180s here, that would be considered fetal tachycardia. If the fetal baseline is in the 90s, you should know that that would be fetal bradycardia. Moving on to the different patterns within this slide. This is a normal range pattern. This is a nice acceleration of the fetal heart rate. So this is okay. Remember that mnemonic. I suggest keeping it out in front of you as we review this slide. It looks like a nice hill. Regarding that early deceleration, remember, early decelerations are head compression. These are good. You don't really have to do any interventions, you just monitor. Notice how there's a drop in the fetal heart rate with the nadir of the contraction. So the nadir of the contraction is the peak. So you may hear peak, you may hear nadir. Same concept, just note that the heart rate goes down with the peak of the contraction. Regarding variable decelerations, this would be cord compression. Again, remember that mnemonic. It's shaped as a V. It's an abrupt drop in the fetal heart rate. Usually drops at least 15 beats and lasts at least 15 seconds. Regarding late decelerations, these are very dangerous. Late decelerations could be a uteroplacental issue. Notice that there's a drop in the fetal heart rate after the peak or nadir of the contraction. This requires interventions immediately, especially if it's repetitive. I don't want you to stress too much about variability, but students always want to understand this concept a little bit more because they hear it when they're on the units. So variability. So it's how squiggly the lines are in the fetal heart rate. Remember, the bottom is the contraction. We're looking at the top right here. This right here would be average or moderate variability. This is a normal fluctuation and it ranges from 6 to 25 beats per minute. If we move down here, this is minimal variability. Note that the fluctuation range is observed at less than 5 beats per minute. Moderate would be the normal one I just discussed, so it's right up here too. It's the same thing. Marked variability would be here. It's a fluctuation in range greater than 25 beats per minute. It's not pictured here, but if you ever have absent variability, just think of dental floss. There's no squiggles. It's a straight line. It's not good. There's no liveliness to the newborn. So again, don't stress about variability, but just know that there are different types, and it really puts into perspective how the fetus is doing in utero. Fetal heart rate patterns are placed into categories, not something you need to stress about, but just know that a category 1 is normal. Category 2 is indeterminate. You do mostly see category 2s. These are very typical, especially as labor turns more active. You start to have little decelerations here and there, and nurses intervene. Category 3, you need to know, is not normal. This is bad. This can result in an emergency to the OR. Category 3 interventions include the following. Always notify the provider and obtain further orders. There's always multiple people in the room, or there should be when an emergency happens. You have somebody documenting all the interventions and the effect on the fetal heart rate pattern, as well as the rest of the interventions I'm going to be discussing. There's a team player for everything. You want to make sure you stop the uterotonic agent. So for instance, if you have oxytocin going through the IV, stop it and discontinue it right away. You want to change the patient's positioning to increase placental perfusion and relieve any cord compression. This could include right lateral, left lateral, knee to chest, as well as hands and knees. Some positions work better than others. I always like to say to educate your patients ahead of time before labor starts to increase too much. They're going to want to know why they're being positioned in all these different ways. It shouldn't be a shock to them. And honestly, a lot of the times it does happen, even with very healthy, labors. You want to administer oxygen with a non-rebreather face mask. You want to increase the IV fluid rate. This is typically lactated ringers. We do not increase that D5W, remember? Increasing IV fluid rate improves intravascular volume and corrects maternal hypotension. And then also you want to prepare for a C-section if the pattern does not improve. I always say stay a few steps ahead and be prepared. Get that poop bucket ready just in case you need to go to the OR. You'd rather have it ready. Uterine contractions are monitored and assessed according to 3 parameters: frequency, duration, and intensity. Note, you need to know the difference between all of these. I guarantee you will get some type of a question that reiterates these definitions. Frequency refers to how often the contractions occur and is measured from the beginning of one contraction to the beginning of the next contraction. Duration refers to how long a contraction lasts and is measured from the beginning of one contraction to the end of that same contraction. So just how long that one contraction lasts. And then lastly, you have intensity. This refers to the strength of the contraction determined by manual palpation or measured by an internal intrauterine pressure catheter, as I showed you earlier. The catheter is positioned in the uterine cavity through the cervix after the membranes have been ruptured. It reports intensity by measuring the pressure of the amniotic fluid inside the uterus in millimeters of mercury. It is not recommended for routine use in low-risk laboring women due to the potential risk of infection and injury to the placenta or fetus. This is a great image to put into perspective the duration of a contraction, the period of relaxation between contractions, as well as the frequency from the beginning of one contraction to the beginning of the next. Preparing for birth includes knowing your patient and their risk, especially infections. Standard precautions are followed. I highly encourage you to wear proper goggles, mask, gowns, and even shoe coverings when attending a birth, whether that be a vaginal or a cesarean. Note, in this picture, the newborn is head down. This is also termed cephalic or vertex. This is important. Nurses and providers should be assessing for this upon admission to labor and delivery. Feet first, or you can also say breech, is an emergency if the newborn is delivering due to the risks involved. Labor stage 1 is the progressive dilation of the cervix from 0 to 10 centimeters dilation. It consists of 2 phases. Note that the initial contact with the patient is either by phone or in person during this stage. First is the latent phase, the time labor builds up. The patient is 0 to 6 centimeters dilated. For a primip, or first-time mother you can say, this phase lasts up to 20 hours, and for a multip, or you can say second-time mother, this can last up to 14 hours. Contractions are about every 5 to 10 minutes and mild by palpation. During the active phase, this is when labor actually kicks in. Cervical dilation is about 1 to 1.5 centimeters per hour, and the fetus descends further into the pelvis. At this point, the patient is usually 6 to 10 centimeters dilated. This is the time the patient is very uncomfortable. For a primip, this phase can last up to 6 hours, and for a multip, this phase can last up to 4 hours. Contractions are much more frequent during this time, about every 2 to 5 minutes, and they increase in duration. They also palpate moderate to strong. Relaxation techniques and paced breathing usually occur during this time. Of course, we don't have a crystal ball, but these are just average time frames. Some patients come to the unit 8 centimeters and don't even realize it at all and have been walking around like that, and others may only be 1 centimeter and very uncomfortable. The following are pieces you should ask the patient during a phone assessment. I want you to know if the patient is encouraged to stay home by the provider. It's important to encourage rest, movement, but most importantly, stay hydrated. Make sure that patient stays hydrated, everyone. Once the patient is admitted to the labor and delivery unit, these are the major pieces of stage 1 assessment. Note that the fetal heart rate is bold. Fetal heart rate is the most important aspect upon admission. Nursing interventions for labor stage 1. You want to provide pain relief. You should suggest pelvic rocking, massage, or even back pressure for pain relief. You want to use touch, such as back rubs, also keeping in mind making sure this is appropriate and if so desired by the patient. You want to use non-pharmacologic measures, so warm water, maybe a birthing ball, and heat pack to the lower back. You can also use pharmacologic agents as ordered and requested. You should monitor vital signs and observe the patient for pain. I don't always ask the patient if they're in pain. I really use my assessment skills by watching them and telling them, if you feel like you need something more, please tell me, but also offering them different things if it appears something may not be working as well. You want to assist them with position changes, which you will see on the next slide. You want to encourage the use of distraction techniques. You want to assist them with relaxation and breathing techniques. You want to provide reassurance and encouragement. You want to participate in their labor process. Maybe they want to do hypnobirthing. You should respect that. Encourage it. You want to avoid repeated vaginal exams, especially following rupture of membranes and any tissue trauma. This is an infection risk. You should know that if a patient has been sipping fluids and is noted to have decreased urine output while in labor, it's important to notify the provider. At this point, I would anticipate an IV to be started with lactated ringers to provide further hydration to the mother and fetus. Think about how hard the mother is working during this labor. Hydration is key. You want to encourage any position of comfort the patient chooses to labor in and give birth. I always recommend the patient to change up their position maybe every 5 to 10 minutes. It really helps with the labor progression. Other ways to encourage movement are to have them walk with support from their partner. This adds the force of gravity to contractions and promotes fetal descent. Slow dancing position with a partner or even the nurse. This adds the force of gravity to contractions and promotes support from an active participation of your partner. Side lying with pillows between the knees for comfort. It offers a restful position and improves oxygen flow to the uterus. Semi-sitting, in bed or on a couch, leaning up against the partner. This reduces back pain because the fetus falls forward away from the sacrum. Sitting in a chair with one foot on the floor and one on the chair. This changes the pelvic shape, helps really engage that newborn. Leaning forward by straddling a chair, a table, or a bed, or kneeling over a birthing ball. This reduces back pain, adds the force of gravity to promote descent. Possible pain relief if partner can apply sacral pressure also. Sitting in a rocking chair or on a birthing ball, shifting weight back and forth, not bouncing up and down. This provides comfort because the rocking motion is soothing and it also uses the force of gravity to help descent of the newborn. Maybe doing lunges by rocking weight back and forth with foot up on a chair during a contraction. This uses force of gravity by being upright. It enhances rotation of the baby through rocking. And then you also have open knee chest position. This helps relieve back discomfort. I wanted to provide this brief slide on bloody show. I just want you to know that blood-tinged mucus is a normal finding. The nurse actually interprets this as a cervical opening and progress of labor. That's because the cervix starts to soften and thin, or efface you can say, and widen, or you can say dilate, in preparation for labor. However, if it is bright red blood, the provider should be notified. I always say, if you aren't sure, phone a friend. Checkpoint. What is the nurse's priority intervention when their patient's membranes rupture? Assess the fetal heart rate, especially if they are moving around. Have the patient take a break. Spontaneous rupture of membranes increases the risk for cord prolapse and even cord compression, so it's important to make sure the newborn tolerated it. Sometimes a patient does have ruptured membranes at home and is in early labor. It is the provider's job to educate the patient if this is the case. Labor stage 2. This stage is the process of the baby moving through the birth canal and out the body. There are 2 phases. The pelvic phase is the period of fetal descent, and the perineal phase is the period of active pushing. There is complete cervical change, and active pushing begins during this stage. The urge to push is felt due to the direct contact of the fetus to the pelvic floor. The patient usually feels more in control of their body at this time. Please note there is an increase in bloody show during this stage. This stage can last up to 3 hours in a patient's first labor and up to 2 hours for subsequent ones. Spontaneous pushing is following the patient's urge and directed by the caregiver. This is typical with epidural analgesia. It's important to assess for bladder distension because voiding and cathetering the patient helps the newborn's head descend further into the birthing canal. A full bladder can disrupt the descent. Labor stage 2 interventions. You want to support the woman or patient and partner in active decision making. You want to support involuntary bearing down efforts. You want to encourage no pushing until strong desire or until the descent and rotation of the fetal head is well advanced. Sometimes the nurse and provider may even have a patient labor down if they have no urge to push. This provides time for the rest of the newborn to slowly stretch the birth canal and make their way down. I apologize if I keep saying baby, fetus, and newborn. Sometimes I tend to change up the words a little bit. Please don't be confused by that. Moving on with interventions, you want to provide instructions, assistance, as well as pain relief. You want to use maternal positions, as I mentioned earlier, to enhance descent and reduce pain. It's okay to have them change their position while they're pushing. There's side lying pushing, there's hands and knees pushing. It really depends on patient preference and what works best. And you also want to prepare for assisting with the delivery. These are other interventions except with the actual birth. So the nurse can help the provider cleanse the perineal area and the vulva. They can assist the baby backup nurse with things with the newborn, such as suctioning and the umbilical cord clamping, maybe taking pictures for the family. The nurse can also provide immediate care of the newborn, so the drying, assisting with the APGAR scoring, as well as the identification. There are many team players during a birth. Checkpoint. During the second stage of labor, assessment would include which of the following? The answer here is A, complaints of rectal or perineal pressure. During the second stage of labor, the nurse would assess for signs typical for this stage, such as complaints of rectal or perineal pressure. It's important for a patient to not push if not fully dilated, as this increases the risk for cervical tearing. You need to know to tell the patient to not push if there are complaints of rectal and perineal pressure if they are not fully dilated, so not fully 10 centimeters. Also, you need to make sure the provider's there. Sometimes they don't make it in time, but please don't let your patient push unless they are 10 centimeters. The third stage of labor begins with the birth of the newborn and ends with the separation and birth of the placenta. During this time, gastric motility and food absorption decreases, which increases the risk of nausea and vomiting during this transition stage of labor. Transition phase consists of two parts, placental separation and placental expulsion. Placental separation is when the uterus the placenta pulls away from the uterine wall. Placental expulsion is when the placenta is actually expelled, which can last anywhere between 2 minutes to 30 minutes. At this time, the uterus is massaged briefly by the provider or nurse to ensure that it is firm. The firmness is what helps constrict blood vessels. This minimizes the possibility of hemorrhage. Normal blood loss is approximately 500 milliliters for a vaginal birth and up to 1,000 milliliters for a cesarean birth. Blood loss over 1,000 or 500, depending on the type of delivery, is considered severe. Postpartum hemorrhage occurs mostly during the third stage of labor, and active management of it can prevent its occurrence. Active management includes administration of a uterotonic agent after birth, such as oxytocin, expulsion of the placenta with controlled traction of the cord. The provider should not be pulling on the cord. And there should be uterine fundal massage after placental expulsion. If the placenta does not spontaneously deliver, the healthcare provider assists with its removal by manual extraction. On expulsion, the placenta is inspected for its intactness by the healthcare provider and the nurse to make sure all sections are present. If any piece is still attached to the uterine wall, it places the woman at risk for postpartum hemorrhage because it becomes a space-occupying object that interferes with the ability of the uterus contract fully and effectively. Therefore, it's imperative that each piece is removed, and if there is any concern, the patient should be taken to the OR for further inspection. Incising the perineum area to provide more space for the presenting part is called an episiotomy. Although still an obstetric procedure, the use of an episiotomy has decreased worldwide. The procedure should be applied selectively rather than routinely. For example, for an emergency delivery of the newborn to shorten the second stage of labor. Think about the healing process of this in comparison to a natural tear of the tissues. Episiotomies also increase the risk of infection. Additionally, this can cause pain during intercourse in the month after delivery, keeping in mind the patient needs to be cleared by the provider before engaging in intercourse. Note that a midline episiotomy puts the patient at risk for a 4th-degree vaginal tearing. This was the best image I could find for you all. It was hard to find an image without copywriting, of course. Perineal lacerations or tears can occur during the second stage when the fetal head emerges through the vaginal introitus. The extent of the laceration is defined by depth, and there are 4. You need to know how to identify each of these. For a 1st-degree laceration, this extends through the skin. A 2nd-degree laceration extends through the muscles of the perineal body. A 3rd-degree laceration continues through the anal sphincter muscle. And a 4th-degree laceration includes all of that, but also the anterior rectal wall. Special attention needs to be paid to 3rd and 4th-degree lacerations to prevent fecal incontinence. Risks for 3rd or 4th-degree lacerations include nulliparity, so have never given birth, being of Asian or Pacific Islander descent, an increased birth weight of the newborn, an operative vaginal birth, so meaning maybe a vacuum extracted delivery, if there's an episiotomy, and if there's a long second stage of labor. The primary care provider should repair any lacerations during the 3rd stage of labor. The 4th stage of labor begins with completion of the expulsion of the placenta and membranes and ends with the initial physiologic adjustment and stabilization of the mother. This is 1 to 4 hours after birth. This is the postpartum period, the start of it. The mother is usually wide awake, talkative, and excited. The focus during this stage is to monitor the mother closely to prevent hemorrhage, bladder distension, and venous thrombosis. Keeping in mind, bladder distension can also deviate a uterus and cause additional bleeding, so always keep those bladders empty. Usually the mother is thirsty and hungry during this time and may request food or drink. Maybe offer them a postpartum cocktail. I like to mix a little bit of ginger ale and cranberry juice for my mothers. The bladder is hypotonic at this time and has limited sensation to acknowledge a full bladder or devoid. Vital signs, the amount and consistency of lochia, and the uterine fundus are usually monitored every 15 minutes for at least 1 hour. The patient will feel cramping-like discomfort during this time due to the contracting uterus, and keeping in mind breastfeeding can also trigger contractions because of that oxytocin. Checkpoint. Let's say you're working on a labor unit. It's very busy and 4 pregnant patients arrive at the same time. Which scenario would require immediate assessment? I'll give you just a few seconds here to think this through. So all of these do sound very immediate, right? But the most immediate one would be A, because these are signs of a potential impending delivery. This is a fully term patient who's having regular contractions every 2 minutes. She's very uncomfortable, of course, and keep in mind it's more than one baby she's ever had. And these are usually the faster deliveries.